It is my pleasure to introduce this morning's session. And this morning we are going to have our translational research presentations, and I will introduce the first speaker. He will speak, we will take questions, and then I will introduce our second speaker. So Dr. Michel De Vos is an associate professor in reproductive medicine and surgery and senior medical director at the Center for Reproductive Medicine at UZ Brussels. Dr. De Vos studied medicine in Ghent, Belgium, and holds a PhD in medicine from the University of Leeds. He is the coordinator of the Freezing Ovarian Tissue and Oocytes Consortium, which encompasses Oncofertility research projects across several institutions in Brussels and has authored over 100 scientific articles in his area of expertise. His current research activities are focused on reproductive endocrinology, polycystic ovarian syndrome, in vitro maturation of oocytes, and fertility preservation. The title of his presentation this morning is Ovarian Tissue Oocytes in Vitro Maturation. Dr. De Vos?
Good morning, everyone. Thank you, Leslie, for this kind introduction, and a big thank you to the organizing committee for having me here. As Leslie introduced, we are both from Belgium, so it's for us a great honor to be here to advocate the use of the techniques we are using in Brussels for women and men confronting cancer. This presentation will be on in vitro maturation of oocytes. It's one of the possibilities that we have to increase the hopes for women and young girls with cancer to have children in the future. Nevertheless, it's one of the least commonly used techniques for fertility preservation, and I hope to explain to you why this is not very commonly used, and I would like to advocate the use of IVM in the setting of fertility preservation. So we are talking about incubating cumulus oocyte complexes in an in vitro culture dish for around 30 hours after removing the cumulus oocyte complexes from small antral follicles. And this is the definition of IVM as it was proposed more than 90 years ago already by Pincus and Ensman. And this definition was also used by Bob Edwards in the 1960s of last century. And ever since then, we have been doing IVM in more or less the same way. There have been modifications to the IVM culture system, but still right now in 2022, we are practicing IVM more or less in the same way as we've been doing for the past 50 years, with slight improvements to the efficiency of the protocol, but still we're not there yet. So there is still a lot of improvement to be done until we can reach the same efficiency as oocytes that have been collected after conventional ovarian stimulation. But here in IVM, so the cumulus oocyte complexes that we retrieve from antral follicles have not seen any ovulation trigger before their removal from the antral follicle. So all they have to do is to become a metaphase 2 oocyte in vitro, and then these cumulus oocyte complexes can be denuded, and they can be, these oocytes, when they are mature, they can be vitrified in the setting of fertility preservation, or they can be inseminated with sperm using ICSI or IVF to become vitrified. So that's the principle of IVM. Who are the most suitable women, patients for IVM? Well, a lot of our experience stems from the ART setting. So the setting where women with a high antral follicle count, polycystic ovary syndrome, can use IVM in order to prevent the possible complications of conventional ovarian stimulation, such as ovarian hyperstimulation syndrome, ovarian torsion, hormonal side effects. There's actually a mild approach stimulation, mild approach technique as an alternative for conventional stimulation. And so this is where the majority of children have been born after IVM, and slowly but surely this technique is also adopted in the setting of oncofertility. Also women who have FSH resistance can benefit from IVM, because this is when the ovaries do not respond to exogenous gonadotropins. But in the setting of oncofertility, how can we implement IVM? Well, basically we're obviously talking about people with ovaries who do not have the time to undergo ovarian stimulation. So if we have fewer than 2 weeks before the start of the chemotherapy, what is usually promoted and proposed to these patients is to perform ovarian tissue cryopreservation if there is a serious risk of gonadotoxicity. But other than that, transvaginal retrieval of cumulus oocyte complexes for IVM can also be done, because this is something that does not require ovarian stimulation. We do not stimulate the ovaries, we just puncture the ovaries transvaginally. We remove the cumulus oocyte complexes, and this can be done really from one day to the other. If you see a patient today, you can perform an egg retrieval tomorrow. There is no need for monitoring, there is no need for stimulation. We do not propose IVM for all women, only those who have a decent antral follicle count are suitable, and according to the literature, it has been found that if a woman has an antral follicle count of 19 or more, there is a good potential to obtain at least 10 mature oocytes after IVM for vitrification. So we do not propose IVM for women who have an AFC below 15, because we really do not want to bring false hope. Other than that, IVM can also be used for incubation of oocytes that have been retrieved from the ovary when the ovary has been removed from the body. So this is what we refer to as X-vivo IVM. So you have an ovary where in the culture dish in the lab, you start preparing the ovary for ovarian cortex freezing, and while you're doing this, you can also obtain immature cumulus oocyte complexes that can be incubated in IVM media. So that's also referred to as OTO-IVM, ovarian tissue oocyte IVM, and the first reports of this technique date from 2003, but ever since then, several reports have been published, with also a few children that have been born after this approach. We most commonly apply ovarian stimulation for oocyte cryopreservation in our patient population, although we must say that more or less 40% of all patients have also undergone some kind of IVM, whether it is a transvaginal egg retrieval for IVM or IVM in the context of ovarian tissue cryopreservation. Nowadays, we do not remove an ovary for ovarian tissue cryopreservation without adding IVM on top of that. So we always combine IVM in those patients who have an indication for ovarian tissue cryopreservation, unless they have recently had chemotherapy, because it's not efficient and not safe to cryopreserve oocytes for women who have recently had chemotherapy. This is just an example of a patient who had been referred by a hematologist. She's 28 years old, she's never been pregnant before, she's married, she's been on the pill, and she's been diagnosed recently with acute lymphoblastic leukemia, and the hematologist is planning high-dose chemotherapy. When we see the patient, we readily perform a blood test for AMH, anti-Mullerian hormone, was normal, completely normal, 2.3 nanograms per ml. I'm not sure if you count in picomoles, but that would correspond to more or less 15 picomoles per liter. Antral follicle counts in total more or less 20. And this patient was seen just before the Christmas break, and we planned ahead. We planned the egg retrieval just after the Christmas weekend. She had the blood test just before the egg retrieval. I'm not sure why this blood test was done, but she had to be in the hospital for her COVID-19 PCR anyway. But this shows you that this patient has very low estradiol levels, very baseline hormone profile. There is no need for ovarian stimulation in this patient. We performed an egg retrieval on the 29th of December. We removed 14 cumulus oocyte complexes, and at the same time, we asked the surgeon to position a portacat for chemotherapeutic entry. So this is something that you can combine. You can perform an egg retrieval, and at the same time, you ask the surgeon to prepare the patient for chemotherapy. We did IVM on these 14 COCs, and 10 mature oocytes were obtained after IVM for 30 hours, and these oocytes were vitrified. So this is something that you can propose to the patient with very little effort, neither for the patient nor for the lab. Another example here is actually more spectacular. It's a very recent case, a patient who was trying to get pregnant. She was diagnosed with polycystic ovary syndrome. She's been using ovulation induction treatment, and then all of a sudden she was diagnosed with stage 2B Hodgkin's lymphoma. The hematologist proposed ABVD, which is a low grade gonadotoxicity regimen, but well, we know that more or less 15% of those patients will not be cured with ABVD, and they will have to go on to a more toxic scheme. And so this means that even for these patients, it makes sense to cryopreserve oocytes before chemotherapy. We did not have time for ovarian stimulation. We did an ultrasound scan and an AMH test, and this came back as very, very high number of antral follicles. She had 60 antral follicles. We saw her on the 27th of April, just last week. We counseled her for an IVM egg retrieval, and 2 days later we performed an egg retrieval. 51 COCs were retrieved, and 30 hours later we had 31 metaphase 2 oocytes that were vitrified. So this, I think, is also an example of how with little effort you can actually bring hope for the future for these patients. Now, but IVM is no longer experimental, and this was issued in a ASRM committee opinion paper in 2020. It is not experimental. It should be regarded as an innovative fertility preservation procedure. However, when you perform IVM of oocytes that have been retrieved ex vivo from the ovary, then this should be regarded as an experimental procedure, because there are still limited data available, no safety studies so far, no long-term follow-up of the very few children that have been born after ex vivo IVM. The potential of these oocytes is also more limited because these oocytes are derived from small, non-selected antral follicles. The IVM protocol for this procedure is still suboptimal, and when you transport the ovary from one center to another where the ovarian tissue is processed and frozen, then the transportation at low temperature may be also an impediment to the potential of these oocytes. So that's also something that has to be improved in the future. But in general terms, ex vivo IVM could be applicable to all women who undergo ovarian tissue cryopreservation, although women who had recent chemotherapy should be excluded from this program, and also very young girls as well. Maximizing the number of oocytes available for IVM requires a total or subtotal ovarectomy. If you only perform a small biopsy from the ovary, then it's very unlikely that you will find many COCs for IVM. it should not be regarded as a standalone technique, but as an appended tool in connection to ovarian tissue cryopreservation. It could also be highly valuable in women in whom ovarian grafting is contraindicated. If there is a high risk of ovarian involvement by tumor cells, grafting of ovarian tissue is unlikely, it's contraindicated, but in these cases, if you have immature oocytes that have been matured in vitro, these oocytes are probably a very important and valuable source of gametes for these patients. But we have to optimize the IVM culture. Here another very quick example of how we can combine techniques in some patients. A 24-year-old woman with a solid tumor close to her spine. She had to undergo chemotherapy on the next day because the tumor was big, was compressing the spine, and we performed oophorectomy on one side, and we performed an egg retrieval for IVM from the other contralateral ovary. And this gave us 6 COCs from transvaginal egg collection and more or less 20 COCs from the ovary when the ovary was removed. So X-vivo IVM yielded more oocytes than the transvaginal collection. This is what we commonly see. And in total, this woman had 14 mature oocytes vitrified on top of a few cortex fragments that were frozen. So actually you can do a lot of things in relatively short time frame. So when the ovary is removed, we need 2 biologists in the lab to process the ovary and to perform IVM. So while one operator is cutting the ovary into slices and is discarding the medulla from the cortex, the other biologist is looking under the microscope, looking for small cumulus oocyte complexes that are coming out from the tissue and that are readily available in the dish. This is what you see here. So we pipette the spent media through a filter, and this allows us to identify small cumulus oocyte complexes. And these complexes are compact. We incubate them in standard media, supplemented with gonadotropins, HPHMG. You could also use FSH and HCG, human serum albumin in air at 37 degrees for 30 hours up to 42 hours. And then after denuding the COCs, you will find that almost 50% of these COCs will have a metaphase 2 oocyte. Now, in terms of ex-vivo IVM, we've been looking at a series that we published in Human Reproduction, 77 women who had ex-vivo IVM, and the mean age was 24 years. The average number of metaphase 2 oocytes that could be vitrified for these women was 6.7. Some women had embryos because they had a husband, and these had, on average, 2 embryos vitrified per case. The majority of women were women with breast cancer, where we removed an ovary, and that was, well, more or less 10 years ago. We wouldn't perform ovarian tissue cryopreservation in women with breast cancer nowadays because other options are available. And, well, the majority, the other big proportion of patients were patients with hematological cancers. After in vitro maturation of these oocytes that were retrieved ex vivo, the mean maturation rate of the oocytes was 42% in adults and only 22% in prepubertal patients. So this illustrates a reduced ability of these oocytes to complete meiosis in vitro as compared to the mean maturation rate of 50% of oocytes that were collected transvaginally. So you're really working with low potential oocytes, but in spite of the low potential, we have seen babies from these patients. So from the 77 patients who had this ex-vivo IVM procedure, 12 women returned with the desire for pregnancy in the years after when they were in remission from cancer. We had a live birth from OTO-IVM oocyte vitrification and 2 live births from women who had this ex-vivo IVM and ICSI and embryo vitrification. You can also see on this table that several women did not have their cryopreserved oocytes or embryos thawed because they still had some degree of ovarian function, and they were able to have live births with the preserved ovarian function after chemotherapy. In children, the potential of ex-vivo IVM is relatively low because in girls underneath the age of 5, the mean maturation rate of oocytes after ex-vivo IVM was only about 5%. So in really young girls, I wouldn't advocate the use of ex-vivo IVM. When we look at survival rates, they are more or less the same as survival rates of oocytes after ovarian stimulation, more or less between 75 and 80%, although the potential of the embryos that will be created with these oocytes is slightly lower. So IVM is still less efficient than standard ovarian stimulation with gonadotropins, because you have to recognize that when you remove the COC from a small follicle, even though the nucleus of the oocyte is able to start meiosis and to complete meiosis, the cytoplasm is probably still not ready to yield a fully competent oocyte, so it's really hastened maturation, and this dyssynchrony between the nucleus and the cytoplasm is probably the main reason for IVM to be a less efficient method compared to standard ovarian stimulation. And on this slide here, you can see that the smallest follicles that yield a COC in the setting of ex-vivo IVM, these follicles, they harbor an oocyte that can complete meiosis in vitro, but the potential of these oocytes is really low because the mechanisms are still immature. So we're looking at oocytes that do not really have the endothelial growth factor peptides. These peptides are not there yet, and these peptides you really need to have a good quality oocytes after IVM. So we still need to further optimize the IVM culture system, especially for these very small cumulus oocyte complexes. One way to approach this is to use meiotic inhibitors, such as cyclic AMP analogs, phosphodiesterase inhibitors. So we're still working on this in collaboration with researchers in Australia. And if we look at safety scores after IVM, I think we can be quite reassured that when you look at epigenetic impact from IVM, chromosomal abnormalities, and also the offspring after IVM, there is no difference when you compare these safety scores with safety scores in standard ART procedures. So that's quite reassuring, although for ex-vivo IVM, these safety scores are still not available. When we look at the overall interest globally in IVM, we can see that the interest is increasing, and even Sherman Silber has recently published a paper in RBM Online where he discussed his experience with more than 20 years of ovarian tissue freezing, and very recently he added ex-vivo IVM to his program. And he was almost lyrical about what he found in these settings. He says that it might at first seem puzzling why IVM from ovarian tissue suddenly seems so easy at many different centers when it has been difficult in the past. Well, I think it has never been difficult to perform ex-vivo IVM, but it was just not used. Nobody was doing it because they said, well, these oocytes, they have very low potential, so why would we care about these cumulus oocyte complexes? But now that there is renewed interest. I think we can find the momentum to improve the system and to convince other teams to start working on these small oocytes. And we have workshops in our lab where we show how to perform IVM, transvaginal egg retrievals, and how to perform IVM ex vivo. And you're definitely more than welcome to come over to Brussels to learn how we do this. Now, in conclusion, we based on our experience and the increasing amount of data, we can say that IVM should be routinely integrated into the number of technologies that we have to maximize fertility preservation prospects for cancer patients, although there is research still required on how to integrate the options of ovarian stimulation with IVM, egg retrieval, and ex vivo IVM into clinical practice. So we still don't know the best algorithm for the patients. Improvement of the efficiency of IVM is really needed, and this requires innovative approaches to IVM culture systems. Thank you so much.
Thank you, Dr. De Vos. We'll take any questions at this time from the audience. I do have one question as individuals are going to the micros, going up. In terms of freezing ovarian tissue and then removing follicles from tissue that has then been thawed, what is the likelihood of success in that situation? Because this is ovarian tissue that has been removed, the follicles are removed at that time. Right?
Oh, yes.
Yes, so then if you freeze the tissue first and then remove follicles at that point.
No, but when you thaw the ovarian cortex, then obviously the follicles that are thawed are embedded within that tissue. So then you have primordial, primary, secondary follicles, but no further than that. So if you wanted to culture the oocytes in these follicles, then we're talking about IVG, in vitro growth, and not about IVM. What we are talking about with IVM is oocytes that are in follicles that are at least in the antral stage, and not before that. So
Okay.
when you thaw the oocytes, well, there is no point in doing IVM because there are no antral follicles.
Thank you. Jen Levine.
Hi, Jen Levine from Cornell. This question is a little bit like of a crystal ball, but I'm curious, you just talk about in prepubertal children, how inefficient it is, but whether you see that as an area where maybe just future movement forward will allow us to get to a position where that's possible. Because I think those two groups, those who have recently had chemotherapy, so like people with leukemia and these young kids, are enormous patient populations that we struggle with. And this kind of IVM from tissue that mostly contains germ cells would be, I mean, this is incredible work. It is so exciting to see, but that would be such a game changer, and I'm just curious how you see that moving forward.
If I understand your question well, you're referring to prepubertal ovaries, right?
Or those that have been exposed to chemotherapy recently so that they don't already have like a high antral follicle count because of that exposure.
I think there is a consensus that we should not try to cryopreserve oocytes that have been exposed to chemotherapy recently. So in these circumstances, we do not bother even about doing IVM because you might have mature oocytes, but what's the potential of these oocytes? There are numerous reports showing that you have gross abnormalities if you use these oocytes. But
so that's actually, sorry, maybe I didn't. So like, let's take the prepubertal, that idea of really taking the maturation from a very early phase. Do you think that there are just limitations that are not able to be overcome, or that they're actually, could you imagine a possibility where IVM could be used from prepubertal girls in a
Well, according to the data that are available in pubertal girls, I would say between the age of 5 and 12, 13, at the onset of puberty, there are multiple antral follicles in these ovaries, and the oocytes that we can mature from these antral follicles, they could have a potential. Although at the moment, we still do not know the true potential of these oocytes. There has never been a cancer patient in remission that came back to use these oocytes that had been harvested before puberty. We are worried that the efficiency of these oocytes might be inferior as compared to oocytes harvested after puberty, because the mechanisms of oocyte developmental capacity, these mechanisms are still incomplete in girls before puberty. And so there is an overall consensus from the studies that have been performed that if you try to make babies with oocytes that have been harvested before puberty, that we might be disappointed in the future.
Thank you.
Hi, Kara Goldman from Northwestern. Thank you. This is incredible work and so exciting. I'm interested to hear your thoughts on, specifically the patients who you're doing this in, because clearly it's the patients who don't have time for STIM, who have these, hematologic malignancies. They're very sick, and I worry about their CBCs. Like, are they healthy enough to put a needle into them? And I was hoping to see a CBC from the patients you presented just to get a sense of like how thrombocytopenic are they? Are they doing, because that's really the population you're thinking about here, I would think.
Okay, I think it's a complex question. I couldn't.
No, the question is, how safe is it to perform the pickup, the retrieval transvaginally in patients who are ill?
Right. So sorry, I'll talk slower.
Yeah, but in patients, so this transvaginal egg retrieval has a very low impact on the well-being of the patient physically. We see that we have several instances where we would like to perform ovarian cortex cryopreservation, but the anesthetist wouldn't put the patient to sleep because she's too sick. She's not in good condition. So when you cannot remove an ovary because you cannot put the patient to sleep, she wouldn't support a laparoscopy with high tension in the abdomen. In these cases, IVM egg retrievals are a good option because you don't even have to put the patient to sleep. You can just give her local pain relief, and if the operator is confident about how to perform an egg retrieval for IVF, it's only slightly more difficult because follicles are a little bit smaller, but the procedure in total takes about 20 minutes to complete, and the majority of patients do not suffer any side effects from that. So in women who are unfit and who need to start chemotherapy really quickly because they are really unwell, IVM egg retrieval is a good option.
Thank you. Yeah, I was specifically wondering about platelet counts just because they tend to be quite thrombocytopenic in that population, but I thank you very much.
Platelet counts. Are you worried about patients who are thrombocytopenic?
Yes, definitely, of course.
Yes.
Yes, no. If we see that the platelet count is below 50,000, then we ask a platelet transfusion before the egg retrieval.
Yeah, great. Thank you.
Definitely.
Hi, thank you. That was a wonderful presentation. How long from the time, like an ex-vivo IVM, how long from the time you remove the ovary from the body until you process the tissue is like recommended? So, there are places that transport tissue to another center for processing. Can it be hours, or does it really have to be, minutes to do that? Thank you.
Okay. Yeah, that's a good point, because the majority of data that I've just presented are based on our local experience where we have everything on site. So all these data are from ovaries removed in our operating theater, and the ovary is then transported on ice to the adjacent lab. So that would only take a few minutes to start processing the tissue. In transported tissue that has been transported for several hours on ice at 4 degrees, we have very little experience, although the Danish group from Anderson has found that the oocyte maturation rate from oocytes that have been retrieved from these ovaries that have been put on ice for several hours, the maturation rate is halved, so it's 50% lower. So probably the long time that these oocytes are exposed to very low temperatures is that's just simply not good for the oocytes, but it's favorable for the ovary. So you have to make compromises. If you increase the temperature, then this will be bad for your ovarian tissue, and it may be better for the oocytes. So where do you want to invest most? I think at the moment we want to prioritize the efficiency of the frozen tissue, and we consider these oocytes as an interesting bonus, but if we have to choose, we would choose for the ovary.
Thank you. We have time for one last question, Dr. Moravec.
I was curious, I have a cohort of FSH-resistant women, and how do you, I heard you say you add gonadotropins to the media, but how do you modify your media for them?
Sorry, can you repeat?
What was the first part, Molly?
In FSH-resistant patients, do you have the same maturation, and do you have to modify the media?
FSH
if we use the
resistant.
same maturation media as in transvaginal IVM. Yes. At the moment, we use standard IVM culture systems that are available on the market. You could use Sage or Cooper Surgicals or any IVM registered IVM culture system that could do. And we know that if we want to perform OTO-IVM and we want to improve that system, the standard available systems are just not good enough, and we have to improve them by adding perhaps a pre-incubation phase where we need to give the cytoplasm slightly more time to complete what it should be doing. But this is experimental. But for the transvaginal egg retrieval, that's just standard media, and that appears to work.
And if they have FSH resistance, do you add more gonadotropin?
No, so we do not pre-treat the patient because it doesn't make sense. And in the culture system, we just add 75 microunits per ml of HPHMG, and we see that the maturation rate is on the low side, but still we have mature oocytes in the majority of these patients. So probably the FSH resistance is based on the deficiency of the FSH receptor on the follicle and not has nothing to do with the oocyte.
Thank you so much.